Start.
So the initial talk today was peripheral arterial disease, but we kind of just switched it around. And I thought, before talking about the peripheral arterial disease, let's talk about the pre-procedure assessment, the hardware, techniques, puncture set, guidewires, and catheters. You need this because in your boards, actually, you'll have at least one question on these kind of things. They'll actually ask you about puncture sets, they'll ask you about the French size, they'll ask you about, there's always one question which comes on the boards on this. And this is the very basics. This is what you actually need to know before you do any angiogram. So let's begin. So first of all, don't have any disclosures. What do you need by pre-procedure evaluation? So this is very important. You need to know what you plan to do. You need to know why you're doing it. Is it a right indication to do that angiogram? Whether it be it embolization, be it stenting, be it just an angiogram. So it needs to be an appropriate exam and formulate a procedure plan. You have to formulate a plan in your mind how you want to approach it. You need to know from where do you want to access, what size sheath you want to place. You want to know what exactly do you want to achieve. So depending on your plan, you will actually have planned from which artery to access, how to canalize it and what to do. Always have a brief history. So know the patient's prior surgical history. So this talk is geared more towards the peripheral arterial disease. So I'm bringing this talk to you because you guys don't see much of peripheral arterial disease, right? It's all done by the vascular surgeons here. So know the prior surgical history. Does the patient have anything which will change your plan? Does the patient have arteriofem bypass? Does the patient have some other bypass surgery, or does have a scar in the groin that you can't access the femoral artery, or there is a reason that they have tried in the past to cannulate the renal artery but cannot do it from the groin, so you might have to come from the arm. So you need to know the prior surgical history, prior interventions, MI, stroke, diabetes mellitus, renal function, allergies. So this is something you need to know. That is why we call our patients to clinic to see them. Know about the medication history. Is there anything that you're going to use that the patient is allergic to? If the patient is diabetic, then is he on metformin? So what do we do about the contrast? So always know about this. Review any available imaging. Before you start a case, majority of times if you see the prior imaging, you can actually, it's very helpful to plan what you want to do. The worst thing is you actually start a procedure and then realize that, oh, I missed something and it was there on the prior imaging. So prior imaging, it could be a CTA, it could just be a CT, it could be a duplex ultrasound. Whatever imaging is available, always look at it. And then do a focused physical exam, especially vascular. So when these patients come to clinic, we always try to palpate their pulses. We want to know, does that patient have a good femoral pulse? Does that patient have a good popliteal pulse? Is the dorsal pedis palpable? Are the radial pulses on both sides palpable? Are blood pressure on both the arms the same? It will make a lot of difference to how you want to plan for the procedure. So what is the pre-procedure management? So briefly, all patients who actually get angiograms need to get hydration. So irrespective, when they come in the morning, as soon as they get blood work done, they need to be started on, for me it's kind of D5 half normal saline at 75 to 100 ml, but they need fluids because they're coming dehydrated from the night, right? You tell them not to drink or eat anything since the night after 12. They come in the morning, they are dehydrated. Their procedure could be at 10 o'clock. So but about 8-10 hours, they are dehydrated. And then you're going to use contrast. So you actually causing trouble to get into renal insufficiency and cause contrast nephropathy. So always hydrate these patients. Usually a CBC to check platelets. You don't need a lot of labs. A BMP for creatinine. This is just for the angiogram. PT and INR if history of bleeding or on anticoagulation. So if there is no history of bleeding, patient does not have a liver disease, you do not need a PT and INR. Out of all these, in an emergent condition, only one test is required. That is, if lady is pregnant, then you need to have a beta SCG level just to be sure that the ladies are pregnant. Everything else is okay. You can in an urgency, you can skip it. And then you need an informed consent. So if you have contrast nephropathy prevention, what do you do? This is again a board question here. So the best thing and proven thing is hydration. So they say 1 ml per kg of D5W for 12 hours before, and then you decrease it to half for 12 hours post procedure. So as long as you hydrate the patient very well, the chance of contrast nephropathy is really decreased. You can use soda bicarb. You can remember this, but it has not been proven that soda bicarb or mucomist is helpful. People believe in it. I believe in it sometimes. I will actually use it. But what is really helpful is the hydration. Contrast allergy. This is another question coming up. So if patient is has allergy to contrast, what do you do? So the best treatment is actually the 13-7 and 1 hour. Remember, 13-7-1, prednisolone 50 milligram only. This is the best treatment. This is not for an urgent angio. This is for a planned procedure. And you can give them Benadryl 50 milligram intravenously on arrival and use a non-ionic contrast. But if you are in an urgent situation where you don't have time to give this, then what do you use is 200 milligrams of hydrocortisone IV about 30 minutes before the procedure. So this is exactly the person where all our angios started from. So this is the Seldinger. You know about the Seldinger needle, about the technique. But before he actually came up with his technique, we never knew how to cannulate arteries, how to enter the arteries. We always had to do it surgically. So this is exactly what he said. I had a polyurethane catheter, the cannula, and the wire guide. I made several attempts to place the catheter into a frozen cadaveric aorta, and suddenly in a split second, there came an attack of common sense. The sequence in which these three items ought to be used suddenly became obvious. This is what changed the way we treat patients today. Be it IR, be it cardiology, be it vascular surgery, any field, they all rely on this technique. And what it is? This is from his paper in Acta Radiologica. Needle in, needle out, catheter over wire, wire out, that's all. So it's simple, but to get to this technique, it took years. So before 1952, we never knew how to do it. We actually would do a surgical cut down for any vascular access. But it just stuck in that you put a needle in, a hollow needle, you can pass a wire, take the needle out, put a catheter over the wire comes out, and now you have access to any arterial system. So needle in, needle out, catheter over wire out, and that's all. So this is exactly how all of this was invented. So these are the percutaneous access needle sets you need to know about. So if you want to, this is the, does anybody know what needle is this? This is actually the old Seldinger needle. So you see you have a trocar inside it here, and then you have an outer cannula. So this is a double wall needle wherein you initially actually, when you do a femoral puncture, you would not worry of going through the posterior wall. You would go all the way to the bone, turn the hub around, take the stylet out, and then slowly pull back till you get into the artery. This is a vascular cath. This is actually a 5 French catheter or a needle. You just slide it in. This is kind of the Seldinger needle that we use these days, the hollow needle. This is a micropuncture. This is a 21 gauge micropuncture. This is a 018 wire. I'll tell you the sizes in a little while. So how we use this, we get access into the artery. We pass this wire. Once we pass the wire, we take this needle out. And this is the 5 French micropuncture set. It also comes with a 4 French micropuncture set. It has two components. You see this inner component, this is a 3 French component, and the outer is 5 French. So what it does is you actually put a 018 wire, over that you slide this, then you take the inner component out, and then you can pass a 035 or 038 wire. So you're basically upsizing it using a small access. Okay, these are the percutaneous access needles. Choice for access is very important to know what are you going to do to choose your access. So wherever there's artery, there's a potential access site. You can access most commonly femoral, you can do radial, you can do brachial, you can do axillary, you can do popliteal, pedal, and distal. So pretty much you can do anything. You can directly access the aorta. So wherever there's artery, there's a potential access site. So you need to know the prior surgical history, what has been done. If this patient has occlusion here, I cannot use the femoral site. If the renal artery comes at a very weird angle, I cannot use the femoral site. So I need to come from above. So need the radial access or an axillary access. So considerations in choosing access site. It's very important to know what is your target area. Where do you want to achieve? So if you want to do something in the foot and you think you need to go from the radial, there is no catheter in the market which will take you from the radial all the way to the foot. So you need to come from a femoral access. So you need to know exactly what is your target area. What is the procedure need? What size of a sheath do you need? If I'm putting an endovascular graft in the aorta and I need a 10 French or a 12 French sheath, I cannot put a 12 French sheath in the radial artery. It's too small an artery. So I have to have a different access site. What devices are you going to use? Clinical presentation, body habitus. So normally we use the femoral access. We use a lot of axillary access. But in a patient who is morbidly obese, it is very tough to get axillary access. If a patient is hypertensive, it is very tough to get axillary access. They bleed a lot. So in those cases, you actually prefer femoral access. So body habitus also plays a big role. And then what previous interventions and surgeries have been done. So just briefly showing you the different access sites. So femoral access, as you all know, we have two types of femoral access. One is known as the retrograde and the antegrade. Retrograde means blood is flowing like this and you access it like this. Okay. Antegrade means we access it in the antegrade fashion. So normally you look for the pulsation. You have to be below the inguinal ligament. Normally you want to be in the lower half of the femoral head. This is where you want to be. So you palpate the artery. You can use fluoroscopic images. You can use ultrasound to find the artery. You don't want to enter the SFA or you don't want to enter the profunda. You be in the common femoral. And if you have a too high a stick, there's high chance of a retroperitoneal bleed. So you actually access the artery, stabilize the artery over the medial half of the femoral head, because you can have compression later on. You access at about 45-degree angle. Okay. This is the antegrade access. So when you're doing a retrograde access, I showed you, this is your target zone. Okay. So you make your nick here, anesthesia here, because the needle is going to go up as a 45-degree angle. When you're doing antegrade access, your nick is here, so that your access site is here. Okay. This is axillary access. You can have a high axillary access and a low axillary access. You can do it on ultrasound. You can do it under just by feel. A brief talk about little bit about radial access, because this is where the whole world is going, especially the cardiologists. They only prefer to do radial access. So people might ask you about the modified Allen or the Barbeau test. So before you do a radial access, you have to make sure that the palmar arch is complete. There is communication between the ulnar and the radial. So this is known as the modified Allen. Modified Allen was where you actually would compress and see if there's any distal flow. In Barbeau test, what we did, we would put a pulse oximeter and we see the waves. Okay, so we have like A, B, C, D. Only thing you guys need to remember is if it's a Barbeau D, that is a contraindication for doing a radial access. So the cardiologists a lot of times will not do this, and that is why they run into trouble. So you need to be sure that the palmar arch is actually complete before you can do a radial access. You can do a popliteal access. Again, popliteal access has 3 different places to do. I'm just showing images of popliteal access. You can do a pedal access. You can approach the dorsalis pedis on the antitibial artery. You have shorter microcatheters for this. This is the way you enter it, and this is actually very useful for doing reconstructions. So in the next talk of peripheral vascular disease, I'll show you cases of pedal access. This is a translumbar access. If you don't have any access and you need to get in the aorta, you can just do a translumbar. You can go straight into the aorta. This was the favorite access a couple of years ago. So people don't worry about it. When you come out with the needle, you'll have a psoas hematoma. It patches up. Just a quick note about the aortofemoral bypass. So if a patient has an aortofemoral bypass, this is how the bypass comes. This is the native vessel. So you normally do not stick the bypass graft. What you stick is actually you stick the native vessel, you get access into it, use a curved catheter, and then gain access into the aortofemoral bypass. Coming to the wire guides. So there are many different types of wires and how they have evolved over the periods. So as I can show you here, this is the Cook wire guide history from 1960s. So there is TFE coated, straight wire, J-shaped wire, and this is the chronological order of how these wires have changed. So you have tapered, movable core, extra stiff, sauce interventions. You'll see that we use different kind of wires for different procedures, okay? So don't need to worry about it. All you need to realize is what are the components of a guide wire. So guide wire has a functional diameter that we always say. You'll see me asking the tech, I need a 018 or a 035 or a 014. This is the diameter of the guide wire. So 035 is the normally guide wire we use. 018 is majority of the micro wires. 014 are also on the micro wires, and also a lot of the cardiology stuff is based on the 014 system. So every wire actually has a core diameter, has a core material, has coatings on it, has coils and covers, a core taper. This is the taper, how long the taper is, and the tip style. Varying these components, you can get different types and characteristics of wires. So every wire behaves differently. There is a different wire for every access. If I want to access a small vessel which is curved, I'll have a different kind of wire than I'm using to access a big vessel which is straight, okay? And all these depend on the wire components. So there are basically 6 things that you can change in a wire, and you can actually get different qualities of wire. The core material, the core diameter, the taper, the tip design, coils and covers, and coatings. So you can have a stainless steel wire or a nitinol wire. So if you have a stainless steel wire, it is more talkable and rigid. If I need some support, I can use this. If I need a nitinol, it is more flexible, won't kink, okay? Similarly, diameter. The larger the diameter, you increase the support. The smaller the diameter, you have less support. You can have taper and grinds. So if there's a long taper, the wire is more flexible, it can negotiate the curves. If the taper is short, it gives me more support. So this is the taper, and this is the distance on the wire. So you can have a 10 centimeter, 5 centimeter, 20 centimeter taper depending on what kind of wires you want to use. The tip design, you can have a core to tip and a shaping balloon. You can have covers. You can have coatings. So coatings is important because some of them are hydrophilic. So you see some of the wires, you keep them wet all the time in saline, and some of the wires we are okay. So like a Amplats, a J-wire, or a Benson, they don't have the hydrophilic coating. If you have a hydrophilic coating, you need to keep in saline. This is because the tactile feel, the lubricity. So if they have a hydrophilic coating, they are more lubricant. They can go into small places. They'll cause less spasm, but they'll have a less tactile feel. So these are some of the commonly used wires. You see a Rosen curved wire. This is a Coons wire. This is a stiff Landquist wire, extra stiff. You know about the Amplats and Amplat super stiff, and the soft wires, the Benson and the Benson Plus. So how do you shape guide wires? You'll see that I shape the guide wires when I need to enter vessels. So that is on the visceral side. I'm talking here about the peripheral arterial disease, if you're crossing a SFS stenosis or something. So penetrating the lesion at the entry point. Straight or small angle at the very distal tip. So you just put a small angle. This is if you want to penetrate through an obstruction. Then you have a secondary bend for navigating tortuosity. If the vessel you're going is very tortuous, then you need a secondary bend. So this can be on the side wall, and this will help you. Small angle at the very distal tip, subtle secondary bend. And the last is re-entering true lumen from subintima. Sometimes when you're doing peripheral vascular disease, you actually are not in the true tract, you are actually in the subintima. And you need to come back into the true lumen. Then you make a more of a J shape. You need vascular dilators in the vascular access system. This is a regular dilator. This is a Coons dilator. See, this has a more gradual taper. So if a patient is very obese and you need to dilate the artery, I'll actually use a Coons dilator rather than this kind of a vascular dilator. Coming to vascular catheters. So vascular catheters have been there since centuries, okay? They were initially used for measuring intracardiac pressures. This is all, I'll not bore you with all the chronology with this. We'll straight away go, so how come vascular catheters came in between? So vascular catheters we got from the urology world. So urology used to use catheters to dilate ureteral strictures. And that is where they came the French scale, the French size. We call about 3 to 5, we always talk about French size, right? So what exactly is the French? So believe me or not, they actually have a French scale, they have a British scale and a Scottish scale. But what is used is the French scale. So this is the actual diagram when the French scale was coming with Coke. So the French is actually 1/3 of a millimeter. This is again a board question. They give you that, they say a 10 French catheter is how many millimeters? There's a question on the boards, okay? I'm not talking about the actual boards, this is an in-service question. So when you measure catheters, you measure them in French, you measure the inner diameter in inch, and you measure the length in centimeters. This French size is the outer diameter of the catheter, not the inner diameter. Guide wires, you measure them in inch and millimeter, length in centimeters. Needles, you measure them in gauge and centimeters. So as the gauge becomes smaller, the needle becomes thicker. As the French size goes higher, the catheter becomes bigger. Sheaths. Sheaths are measured in French, but this is the inner diameter. So always if I'm saying a 5 French sheath or you're talking about a 6 French sheath, it means it has space to accommodate a 5 or a 6 French catheter. It does not mean that that is the outer diameter. So the French size of sheath, actually the outer diameter is 1.5 French higher. So a 5 French sheath actually is 6.5 French in size. But the 5 French sheath will accommodate a 5 French catheter. Okay? Stents are measured in millimeters and the length is measured in millimeters. So the only thing you need to remember is catheters, outer diameter is measured in French. Sheaths, inner diameter is measured in French. Okay? This is again how catheters. So these are one of the initial catheters, the actual Kifa catheters that were manufactured in 1955. And again, catheter can have different constructions, different materials, braided, non-braided, given tensile, you can have different shapes of catheters, okay? So what does actually a catheter all have? So catheter, you can have torque, you need it to torque. So if you have braiding, this is the braiding, you can torque the catheter, move it around. Body, is it made of nylon or what? So it is material resist softening. Selection, so you have different catheters for different shapes, and then a soft tip or a what type of catheter tip is there. So this is the tip, this is the material, this is the shape, and this is the braiding. So depending on these, you can have different catheters. So these are the commonly used type of catheters you will see. This is a straight catheter. This is an angled catheter, okay? This is like a Cumpy's angled catheter. This is a MPA, multi-purpose angle catheter. This is a head hunter, has a secondary curve. This is, looks like a Cobra, right? This is the Cobra. This is the Roche visceral, celiac or SMA. This is the visceral selective. See the shape? This is a reverse curve catheter. This has a back support. This is a Mickelson's catheter, normally used for bronchial artery embolization. This is a Simmons catheter. This is a pigtail catheter, and this is known as a tennis racket catheter. It looks like a tennis racket. Okay. So these are the different shapes of catheters. You can have an angle catheter, a Dave, a Tegmeyer, MPA, ABC, Cumpy. These are the visceral catheters. These are the Cobra catheters, the rim catheters, visceral selective catheters. Similarly, you have pulmonary catheters. These are normally larger size catheters known as the APC, APC Davis. You can have the coronary catheters. And then you have sizing catheters. Sizing catheter means these catheters actually have marks on them. So these marks help you to realize how big that vessel is. So these are the cerebral catheters. So cerebral shapes are very different from shapes used in the visceral. So when you need to know what is your target vessel to use the right shape of catheter. And you also need to know the anatomy of that vessel to use the right shape of catheter. Okay? These are the pulmonary angiocatheters to gain access to the pulmonary arteries. So every catheter actually has a curve. It can have a primary curve like this, only one curve, or it can have a primary, secondary, and tertiary curves. This is the Cobra. So this is the primary curve, this is the secondary curve, and this is the tertiary curve. This is like a Simmons, has a primary and a secondary curve. So you need to realize that these catheters can be distinguished on these curves. Which type of catheter to use? There's also a question on this and the in-service. So if the angle is less than 60, this is the main artery aorta, this is any branch. If this angle is less than 60, all you need is a simple angle catheter, okay, for a stable access. If it is from anywhere from 45-60 to about 120, you can use a curved catheter like a Cobra catheter. If it is more than 120, then you need to use a reverse curve catheter for stable access. So this is the science behind different shapes of catheter, why you need different shapes of catheter. How do you use a Cobra catheter? You'll see me using this a lot, a Cobra or a RC2. What we do, we go proximal to this lesion, there is no wire here, see? And we just scrape the wall slowly, and as soon as we come here, it hooks into it. Once we hook into it, we can pass a glide wire and then get a deeper access, okay? This is how you use a Cobra catheter. How to use a Simmons or a reverse cuff catheter? So this catheter, you cannot just pull back. You need to have a small amount of flexible wire, like a Benson wire hanging here. You come here, the wire is what actually hooks into the artery, and then once you have a little bit of wire, you just pull the catheter down and it goes distally into it, okay? Reforming shapes. So this catheter, when goes in, forms its shapes on its own. But you have this catheter, this cannot form the shape. Outside the body, this is like this, but when you're putting it in through a sheath, it is going to straighten up, right? So you need to form this shape before you can use it. How do you form these shapes? There are multiple techniques. One is known as the aortic spin technique. You take the catheter all the way to the aortic arch, pull the wire back, and now you rotate, twist the catheter. As you do a twist, this catheter forms the shape. Basically, this catheter to form the shape needs this much of space, which is not there in the descending aorta. Ascending aortic technique. What you do, you pass a wire all the way to the aortic valve, bounce it off the aortic valve, and then you pass this catheter. Now it forms a shape. Now you pull the wire back, pull the catheter back. Okay. Branch vessel technique. You can actually pass any catheter, go up and across the bifurcation, pass a wire there, keep your wire there, get this catheter in, and now as you twist it, this will form a shape. Cope string technique. This is basically where you actually put a wire and load a little bit of a string. This is actually a 4-0 suture. This much of is inside the wire. You let it go inside the patient. You come to the bifurcation side. Now you actually pull on this string and push the catheter up. As you do this, you can form the shape. Then you can release the wire, pull the string out, and you can form the shape. This is the deflecting wire technique. So in this, what you have is you have a catheter, you put this deflecting wire. As you press this deflecting wire, this forms this shape. As it forms this shape, it will turn around in this. Be careful of using the deflecting wire technique in patients who have atherosclerosis of narrow aortas, can cause dissections. And this is a Waltman loop. So you might have seen this when Dr. Weir does UAEs. He first goes to the opposite side, but when he comes to the ipsilateral side, he uses a different shaped catheter, right? So that is one catheter, but the traditional way of doing it is actually forming a Waltman loop. So you just put any catheter, curved catheter like a Cobra, you pass your wire here, this much of catheter inside, and then you spin the catheter up. As you're spinning the catheter up, it forms this shape, and you can pull it down into the iliac artery on the same side, internal iliac. I still do that. A lot of people are worried for this because what have happened is when they have formed this loop, they've actually entangled and formed a loop in the catheter, a knot. So that becomes problematic, but a lot of people still use it. This is what Dr. Weir used, the UFE type of catheter, which actually will go in and form a shape there. Side hole catheters. So all those catheters only had one hole in the distal tip, okay? But there are catheters which have apictal catheters, have side holes. Why are these? These are known as flush catheters because you can do high pressure. You can do 1000 to 1200 psi. Before you use a catheter, know what is the psi maximum on that catheter. You don't want to burst the catheter. So the diagnostic catheters are normally 700 to 800 psi. This is 1000 to 1200 psi because this has multiple holes. So contrast does not only come from here, contrast comes out from everywhere. So it gives you a much better run, but this is normally used for aortograms of big vessels. Okay. Side hole catheters are here. See, these are the side holes. This is sizing catheter. Sizing catheter means you need to know the size. So this is like a sizing. Every 1 centimeter there's a mark. So when I do a TIPS, I actually put the sizing catheter to know the size of the stent. When you do peripheral angioplasty, you need to know the size of the stent you need to put in. This is a cava catheter, which is at 3 centimeters because more than 3 centimeters or 2.8 centimeters is a mega cava. So you cannot put majority of the filters in a mega cava. So whenever you put a cava in a filter, you actually do a venogram. You measure with this that the cava should not be bigger than this. This is known as a punch hole device. This is for making extra holes. So if you have a catheter in which you want to make extra holes, you can actually make extra holes in the catheter by doing this. Sometimes when you're doing adrenal vein sampling or you're doing venous sampling, if you only have one hole in the distal end of the catheter, you are not able to pull blood because it kind of goes to the wall and it stays there. You cannot aspirate. If you have another hole, aspiration becomes easy. So we have this now, we can make extra holes. Coming to microcatheters, that was all catheters. So microcatheter, basically, a typical design has these different components. One is a O27, which has a lumen size. So this is a high flow lumen, so this you can put bigger particles. It has a polished tip and an RO marker to see where the position of the catheter is. It has technology polyfusion technology to resist kinking and buckling, so the whole catheter has this. It has braided. These catheters are braided for meta support and tracking. Hydropress means they have coating on the inside so that the embolic material goes very smoothly and easily. And they have a hub here which you can efficiently deliver embolic. So when you use these microcatheters, you have seen me using them. These are the 6 components of a microcatheter. Just one slide on the radial access. This is coming more and more. So initially the problem with radial access for us was we did not have long enough catheters. FDA was not approving it. So radial access came to the cardiology world. See, the heart is closer, but if you have to do any vessel interventions or below the inguinal intervention, you need long catheters. So these are the type of catheters that are now available for radial access. This is known as a Jackie, and this is a Sierra. So these are different shapes. These are vessel catheters to be used for radial access. Okay, I spoke about sheaths to you, right? So let me just briefly describe sheaths. So sheaths can be gliding catheters, introduced in sheaths. There are 3 different things. So sheath, I told you, 5 French sheath will accommodate a 5 French catheter, right? So its outer size is actually 6.5. But a gliding catheter is separate. Gliding catheter is like a sheath, but it takes the same, if it's a 5 French, its actual size is 5 French. So you'll see, sometimes I use gliding catheters, you see gliding catheters being used a lot in neuro. So a 6 French gliding catheter does not mean it will accommodate a 6 French catheter. It means that size of the catheter is totally 6 French. They come in different shapes and sizes. So you can use different shapes, like I told you. So it's a different, see. So, and the sheath actually is different. The sheath actually, the size of the sheath is the actual size of catheter accommodate. Don't confuse it with gliding catheters. So you can have different sheaths. Every sheath has a check flow here. See, this is a check flow. So you basically, what you do is you put a wire in. This wire is down to 038. Over that you can dilate, put this sheath, and you take the dilator out and you flush through this port. You can also inject contrast and flush through this port. So the introducer sheaths are measured by the inner diameter. The guiding catheters are measured by the outer diameter. Okay, so guiding catheters by outer diameter, and you can have different shapes. You can have a multi-purpose 40% angle and straight, depending on what you want to use it for. Vascular sheath can also be a typical hemostatic sheath that we normally use in vascular surgery, or sometimes you can have a peel-away sheath. We use these peel-away sheaths when we are actually putting in ports. When you put in ports, you see that we peel away the port, right? So we put our catheter through it and then we just peel it away. So remember, there are peel-away sheaths and vascular sheaths. Just a quick about the radial access, because I showed you radial access. So after teaching you all that, the 6 French sheath will be 7.5 in size. This does not hold true for the radial access. So in radial access, the concept is we want to use as thin a sheath as possible. So this is the conventional 6 French sheath, okay? So the 6 French sheath, which I use in the groin, actually is about 2 millimeter thick. In radial access, we have slender sheaths, which actually are 0.12 millimeter, okay? So there are also sheaths in radial access which are like a 5 French sheath, which outer is 6.5 but can accommodate a 6 French catheter. So radial access has some different sheaths. So in conclusion, always know your patient. Know what you want to do. What is your target zone? What do you want to achieve? Have a plan. How do you want to achieve it? Are you doing a diagnostic angio? Are you doing some intervention? If you're doing intervention, do you think you have the right access site? Do you have right equipment that you need to know? Be familiar with the interventional tools, because it makes a difference if you get access. The other day I was at cardiology, last Thursday, not this Thursday, before that, they called me for an axillary stenting and they did not have a long enough sheath. So they started the case. Now they have access, but they don't have the right sheath. It took them 20 minutes to find the right sheath from vascular surgery. So know your tools, know exactly what size sheath, what wire, what guidewire you want, through what sheath, what stent will go, through what sheath, what balloon will go before you start a case. And be prepared to innovate. You will have things which you will have to innovate on the way going forward. Any questions? Yeah.
So when do we use the antegrade femoral access as for the retrograde?
So you see us using all the time retrograde, right? Antegrade is used actually when doing peripheral arterial disease. So if I'm treating, so there are a couple of concepts. I'll show you cases of peripheral vascular disease next time. So when you are treating the iliacs, it's okay. But if you're treating the femoral, you can come up and across. But if you're treating anything below the knee, if you are recanalizing anterior tibial, posterior tibial, or you are recanalizing plantar artery. So remember, the farther you are away from it, you lose your pushability of the catheter. So what we do is, when we do diagnostic angios, we'll use the retrograde technique. But when I have to intervene, if I have to put a SFA stent, if I have to recanalize the blocked SFA, if I have to recanalize the popliteal, I have a much better chance if I have an antegrade access. So the problem is, again, this is something which has been used for years. Vascular surgery uses it here. Cardiology have no concept about it. So when you go up and across and you have a very bad arch, so all peripheral vascular disease is in patients who actually are older, right? They have atherosclerosis. So when you go up and across the arch and you have to get your sheath across, you might lose the tensile strength. So it's easier to just come direct access to the femoral artery. The only problem that happens is your wire tends to go into the profunda, because that is the shape how it is. So don't worry, let it go to the profunda, get your micropuncture set in, slowly pull the micropuncture set back, and your wire will go into the common SFA. That's where you use antegrade access.
How often do you flush your catheter with the heparinized saline?
So I flush it after every time. Every time a wire goes through it, I'll ask for flush. Every time I place it, I flush it. Because
it's not being used for like a minute or 2 minutes.
Yeah. I keep flushing it. Keep flushing it. It becomes really important if depends where your catheter is. If I'm already hooked up into an artery like a celiac, then I'm okay. But if the catheter is just lying in the aorta, especially if it's in the arch, then every 1 or 2 minutes I'll keep flushing it. Something else we also do is we actually, when we place the sheath, we hook the sheath to heparinized saline. So there is constant flow, there is no clot forming in the sheath around the catheter. These things, flushing is very, very important when you are doing neuro cases. So you going to the arch, you're trying to hook up into the carotid arteries or trying to whatever vertebral. So you try it once, try it twice, try it 3 times. After 3 times, wait. Pull the catheter back, flush it. You do not want to throw any air into the cerebral circulation. You'll give the patient a stroke. Okay. So flushing is a very good technique, and always how you flush, you hook it up to saline, you turn it up, tap, 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 pull back, tap the air, get the air back, and then you flush. Okay. So flushing is very, very important. You don't want your catheters to clot. You don't want any clot to form the catheters, and you don't want to throw any of the clot or air into anywhere circulation that you. So venous side is still okay. Venous side, you don't worry, because in the venous side, even if you inject 50 cc of air, nothing really happens, because it all goes to the lungs, except if patient has a cardiac shunt or a P4. That is trouble. Then they can have trouble, but normally doesn't. The other thing we do to save us from any air going is we actually put a filter. There is a filter, we put it on the from the heparinized saline before we hook it up to the sheath, and that filter actually takes away all the air. That acts like a filter. Also very important to use a filter in patients who actually have pulmonary AVMs. So these pulmonary AVMs act like shunts, right? They can actually bypass the heart and they can go straight to the brain. That's why they tend to have cerebral abscess and also. So you ought to be very careful there.
President, you know that with Guidewire, there's one end that's stiff as your mama, and the other one's a floppy end. So make sure you put the floppy end in. And if you put the floppy end, it's just barely outside the catheter, it is hard as a rock. It could perforate a vessel. That's why you have to have a little bit more out to get the floppy part. But that floppy part, if it's just barely sticking out, it will be like a needle. And then when you had that other one, when you said you put something in to make a new hole, could that throw a little piece of plastic out?
Yes. So there is a technique of doing. So this is what you make a hole in, okay? So what you do is, you see these are a couple of things here. So basically you make a hole on this side. What happens is you only make a hole on one side of the wall. You don't make a hole through and through both sides of the catheter. When you make a hole, that plastic piece actually goes inside this. And this is something to push that piece out. So before you use that catheter, you always have to be sure where that piece is gone. The other thing you do is you do not flush that catheter beforehand. You make the hole first and then you flush it. So that in case it was inside the catheter, it still comes out. But you have got to find this hole.
So you're making a hole outside of the patient.
Yeah. So you make a hole on the table.
If it was in the
No. You make it outside the patient. You add an extra hole. You need to aspirate something, or you need to add some holes. So this is a punch device to make extra holes.
Thank you.
You're welcome.